Hi everyone, this lecture is titled Managing Chronic Non-Cancer Pain in General Practice with a focus on the use of pharmacotherapy, particularly opioids. My name is Nick Christelis. I'm a specialist pain medicine physician. I'm also an anaesthetist but only practice pain management and one of the founders and directors of Pain Specialists Australia. This is my why. This is why I only practice pain management, because my aim is to rid the world of pain. Now that's a big ask, but pain is a huge problem, as you know. There are many people out there suffering from persistent pain and other pain conditions, and my aim really is to improve the practice of pain medication as well as the practice of neuromodulation, which is one of the advanced pain therapies that can be used for some patients. Today the discussion is on opioids, and it's not necessarily on how to use opioids for chronic pain, but really we know that opioid therapy is being used for chronic pain. The aim really is to have a plan moving forward for patients on opioids, have a plan moving forward to limit the use of opioids, and really have a better understanding on chronic pain and how and if opioids can be applied. So this is the structure of the discussion. Where do opioids fit? We'll talk about side effects, we'll talk about benefits, we'll talk about specific opioids. We'll touch on a couple of those, and we'll spend quite a lot of time on safe opioid prescribing practices, and of course then touch on weaning of opioids in some unique situations. Final slide will be on how and when to refer to pain specialists, because it's an important aspect to understand. So these are the documents that are out there at the moment that are quite prominent out there, and this is from NPS Medicine Wise. But this is what the discussion appears to be moving towards, starting conversations with patients about opioid tapering, how to taper opioids, pamphlets for patients, lowering your opioid dose. So we're talking about things differently. The WHO, I think it was in the 80s, really focused on cancer pain, and there was a big push to treat cancer pain effectively. And what that meant was there's a huge amount of opioids being used for some pain conditions, notably cancer. That spilled over into the use of chronic non-cancer pain. And that's been the focus of therapy for the last 10 or 15 years, and again in Western countries, particularly places like the United States, and to a degree Australia as well. And what we've found is that the evidence for use of opioid therapy in chronic non-cancer pain is limited, and the pendulum is now swinging the other way. And this is why we're now talking about lowering doses, tapering opioids, using non-opioid approaches to managing chronic pain. And this is the message that is coming across. There is a limited role of opioids, and the importance of non-pharmacological treatments when managing chronic pain is so important. So we're moving away from opioids, we're moving to non-pharmacological therapies to managing pain. Let's just have a look at a couple of statistics again from NPS Medicine Wise. Every day there are 3 deaths related to opioid therapy. There are many hospitalizations, up to 150, and there are many emergency department presentations, and the numbers all stack up depending on where you look, but effectively opioids are playing a huge role in causing side effects, in causing harm to patients, and being fatal in some instances. Again, this is from NPS Medicine Wise. Have a look at the top line. The aim really for managing chronic pain is to optimize non-opioid management for patients with chronic non-cancer pain before trialing opioids. So you've got to have a plan of action, and you've got to have a non-opioid plan of action moving forward. If you're going to use opioids, you need to assess the benefits of harm before considering an opioid trial, and these are in patients that have not been responsive to other treatments. And have a look at that diagram at the bottom. Benefits are small, Harm is big. We'll come to the harmful aspects at a later point, but they include death, depression, falls, fractures, hyperalgesia, which I'll mention, opioid use disorders, cognitive dysfunction, respiratory dysfunction, and the list goes on. Benefits are not there in terms of looking at the studies. 2018 meta-analysis, 96 randomized controlled trials, 21,000 patients. There was no clinically important improvements in pain and function in patients taking opioids compared to placebo. And another long-term RCT comparing opioids to non-opioid therapy found treatment with opioids was not superior to non-opioid therapy over the course of 12 months. This is from the Faculty of Pain Medicine, Australia and New Zealand College of Anaesthetists. These are their recommendations. So this is the PM01 document, which can be found on the Faculty of Pain website. It is clear that opioid pharmacotherapy cannot be considered to be a core component in the management of chronic non-cancer pain. The FPM recognizes that at the present time, opioids are widely prescribed for chronic non-cancer pain, despite the lack of clear evidence of efficacy. Given this reality, the following principles are offered to guide safe prescription, and we'll come to that, how to safely use opioids. Side effects of opioids. Let's spend a few minutes on this. So there are central side effects, there are peripheral side effects, there are many side effects. The highlighted ones, the ones with an asterisk, are really the long-term side effects that are very important, and that's what we're talking about here. Drowsiness, somnolence, cognitive dysfunction, risks of falls. If you give it to an elderly patient, they've got comorbidities, they have a trip, they have a fall, they break a bone, could be a fatal event. Got to be careful. Multifocal myoclonus, sleep depression, sleep disorders, opioids, and I say this to patients when I'm educating them, opioids destroy sleep patterns. It's been studied, it's been confirmed, and then they end up on other medications to help sleep. So a tip really is, if you're going to use opioids, or you have a patient, you've inherited a patient on opioids, or one of your patients is on opioids, and you want to start that discussion, show them what the side effects are. Patients respond to the risk of falls. They understand that. They respond to sleep disorders. They respond to understanding what sleep apnea is and that it can be made worse with opioids. They don't always respond and understand what opioid-induced hyperalgesia is, but you've got to explain to them that at some point the opioids become the problem. Hyperalgesia is a heightened pain sensitivity, and that can occur because of the chemicals themselves. And this is following studies done in the anesthetic world, where patients get opioids in the perioperative setting and they wake up with the more severe or severe pain compared to those that don't get certain opioids. So opioid-induced hyperalgesia is a phenomenon. Tolerance, dependence, aberrant behaviours. Have a look at the peripheral side effects. Patients respond to being told that they get opioid bowel dysfunction. So that's not just constipation, it's anything from the mouth all the way to the bottom end. Slows gastric emptying, reflux, gastroesophageal reflux, pain, stomach pains. Constipation is one of them. So there are many effects that opioids can have on the gastrointestinal system. Immune changes, immunosuppression can occur, and I've mentioned that at the bottom of the graph, the table on the right hand side. Opioids can suppress immunity. There are major studies going on looking at the way we apply anesthetics to people having cancer surgery. Heavy opioid-based anesthetics put people at risk of cancer reoccurrence because they suppress the immune system. Non-opioid-based anesthetic techniques, regional techniques, reduce that risk of cancer reoccurrence. That's having a direct impact on disease. We don't know what the effects of long-term oral opioids are on immunosuppression. We know it can occur, and we know it may be substantial. Hormonal changes. If you tell patients it drops your libido, hypogonadotropic hypogonadism, and a number of other aspects, patients get it. We've mentioned risk of fractures, osteoporosis, osteopenia, and of course dry mouth and tooth decay as well, big factor. So, are there any benefits to the use of opioids? Well, yes, opioids can and should be used in acute pain. opioids can and should be used in cancer pain or palliative care. One of the factors, and again in GPs that I talk to a lot of, say to me, one of the issues is when opioids are used to treat acute pain, the opioid therapy persists into the general practice. So we should be, as a community, we should be treating acute pain using as little opioid as possible, and using multiple other non-opioid therapies. So really, when opioids are used for acute pain, we should be using the lowest dose for the shortest time. And there's no reason why we can't get away with using opioids for acute pain for about 3 or 4 days. We don't need to give 7 days, 10 days, 20 days of supply. So we should be reducing that supply of opioid out there in the community that can be misused or diverted. So this is from the Faculty of Pain Medicine, that same document I've previously mentioned. The efficacy of opioid therapy is supported by strong evidence from RCTs for acute pain, for cancer pain, palliative care, yes. And as opioid replacement therapy for dependence and addiction. In chronic non-cancer pain, there is some of the reviews show modest short-term benefit only. Those reviews have only gone for about 4 months, and there's nothing really to give us evidence in the longer term period. So let's have a look. This was a recent systematic review. It was concluded that, and I'll just go through this, evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. It's not just about pain control, it's about functional restoration, and the evidence is not just there. But there is a dose-dependent risk, so the more you give, the more likely it is to occur of harm. And that's psychoaddictive agents, including, and particularly when they're combined with other medications like alcohol and sedatives. This is from the role of opioids in GP document, and that's the part two of the document. The same thing is said. Guidelines identify only a select place for opioids in the management of chronic pain conditions. Opioid is not routine and is not first-line or second-line therapy for chronic non-cancer pain. And it should be used, if you're going to use it, in a select group of patients with moderate, severe pain where it affects their function and quality of life, and that has not responded to other therapies. So that's what the College of GPs currently recommends, a very small group of patients. Let's talk about specific opioid therapies. If you're going to go down the route of opioid therapies, I would consider buprenorphine, tapentadol to be quite useful. It's important to have an understanding of tapentadol. It's not a type of tramadol. They're two completely different medications, but nevertheless you can consider one or the other of these. Tapentadol is strong, whereas tramadol is weak. This is in terms of its opioid activity. Tapentadol is a strong inhibitor of noradrenaline, whereas a weak inhibition of serotonin, so it's less likely to cause serotonin side effects. Tapentadol is an active medication, and the onset is about 30 minutes compared to a prodrug with an onset of about 60 minutes for tramadol. And tapentadol doesn't interact with CYP 450 system, so it's a little cleaner in terms of drug interactions and variability. So tapentadol, if you compare it to tramadol, is probably a safer, more effective medication. And tapentadol can be used in those mixed nociceptive neuropathic conditions, so joint dysfunctions, degeneration, arthritis. You might consider tapentadol if you're getting into that realm of third-line therapy. Nevertheless, it is a scheduled medication and has risk, so treat it like an opioid. Transdermal preparations, just to mention a couple of dose conversions. Buprenorphine, I may consider it in somebody that's particularly elderly, frail, with comorbidities, in terms of helping them with chronic non-cancer pain. 5 microgram per hour buprenorphine patch is equivalent to about 10 milligrams of oral morphine per day. So quite a small dose. You would consider it in somebody that has difficult to control pain, and you're considering using opioid therapy. I sometimes use buprenorphine in these situations. Fentanyl, Personally, from a chemical perspective, shouldn't be used in chronic non-cancer pain. I think the PBS is going to reclassify fentanyl only for cancer pain, but really just showing you a dose conversion. A 12 microgram patch of fentanyl is equivalent to 45 milligrams of oral morphine per day. You're already over the 40 milligrams of OMED equivalent per day, so you're already in moderate dose therapy range. That's just with the lowest dose of fentanyl. 100 mics of fentanyl is equivalent to 360 milligrams of morphine per day. So I would challenge you to consider other forms of opioid therapy than fentanyl, and possibly even challenge you to consider using not using fentanyl in your treatment algorithm. Fentanyl causes quite quick tolerance. It can cause hyperalgesia, and of course has the side effect profile. So consider tapentadol, consider buprenorphine. There are many ways of calculating opioid dose equivalents. The Faculty of Pain Medicine has got the opioid calculator. I think there's one at on the GP college as well. So have one at hand. You can download this app. It takes you 5 minutes to install onto your smartphone, and you can use this safely during consultations, and even use it to show patients what their morphine equivalent is per day. And again, a nice way of developing a rapport with patients so they can start understanding what they're taking. Safe opioid prescribing. If you're going to do it for that select group of small patients with moderate to severe pain, quality of life is not good, function is not good, and they're debilitated, then we've got to do it properly. We've got to do it safely. And we're going to go through each of these steps in turn. I think it's very important. It was important 5 years ago, 10 years ago. It's still important today. Before you're going to prescribe opioids, have a comprehensive assessment. Have a multidisciplinary assessment. Remember what I said: assess the pain, assess the person in pain, assess nociception, assess pain, assess the pain experience, assess their function. Ask yourself if this is neuropathic pain. If this is neuropathic pain, you treat neuropathic pain accordingly. Use the algorithm for neuropathic pain. If there is lack of function or yellow flags, functional debility, use the allied health team. Say we're going to do this first before we come back to opioids. Treat the cause of pain. If there's a facet joint pain that you think it is, get them to a pain specialist to have a medial branch block. Have a radiofrequency of that facet joint if appropriate. Treat the cause if you can. Treat the pain condition. If it's complex regional pain, early, they need to see a pain specialist because pain specialists can help. Comprehensive assessment to start with. Examine your patients. Try and understand what's going on. Is this a musculoskeletal pain? Is this a knee osteoarthritic condition? Is there some neuropathic features around the knee? Or maybe it's a mixed pain. Did you know that about 7% of osteoarthritis of knees and hips can present with a neuropathic pain element? So do I need to treat neuropathic pain? Always ask yourself this. Is there substance abuse, which I'll come to, and that's more of a screener for risk of opioid, which I'll come to in a little while. So examine the patient. Do that psychological screening that we touched on previously. What are the orange flags? What are their psychiatric problems? Substance abuse, PTSD, high levels of distress. Now, if you're going to get somebody with high levels of distress, PTSD, and opioid, they may end up taking it not for their pain, but to cope chemically. So opioids are then used for the wrong reason, and you can go down the misuse route. So patients end up taking opioids to manage anxiety. I remember a patient once came to me and said, I get to the end of the day and there's nothing I prefer better than to get to the end of the day, pour myself a nice big glass of red wine and have a 20 milligram OxyContin tablet with my glass of wine. She was treating a hard day at work with a dangerous Schedule 8 medication, the wrong use of medications. Assess the yellow flags. What is cognitions? What are behaviours? Is there anxiety? Is there depression? What can I use the allied health team to manage before I consider opioid prescribing? You have to risk stratify your patients. You've got to pause. You've got to think about if this is appropriate. The opioid risk tool is a very simple tool. It's validated. You should be using some form of screener. I'll go through it. There are 5 steps. Is there a family history of substance abuse? Is there a personal history of substance abuse? Are they young, 16 to 45? Is there a history of pre-adolescent sexual abuse? Now, you're not going to ask any patient this. You're only going to ask a patient that you've got a rapport about this, but it's important to consider because they score high if there has been a history of sexual abuse. And is there psychological disorder, as mentioned? So different things involve different scoring. Prescription drugs score higher than illegal drugs or alcohol, so this again is a validated tool. Spend 5 minutes and go through this. Low risk 0 to 3, moderate risk 4 to 7, high risk more than 8. You don't want to be using opioids in the moderate to high risk categories if you can. If you're going to use opioids, this is how you would use them in these categories. Low risk, you could probably manage the patient yourself. You could have a verbal agreement with the patient. You might want to do urine drug screening. You might follow up patients every few months. And you might dispense for a period of time. If it's intermediate risk, you might consider getting a pain specialist involved, whether it be pain or addiction. You might put it in a written agreement so you've got a contract. You might do urine drug screening a little more often. And you might dispense for a shorter period of time. High risk, you're going to use a pain specialist and addiction specialist. Definitely going to be a written agreement and a couple of other pointers. But I would advise if you've picked up high-risk patients, then you would use other forms of non-opioid therapy or engage specialist services early. Screener and opioid assessment for patients with pain. This is the short form. 5 questions. We use this in our pain questionnaire. And again, pretty straightforward. And if they score above a certain number, I think it might be 4 if I remember correctly, they're at risk. So you've alerted yourself and you may not choose to use opioids. This is from the GP document. Risk stratification, another way of looking at risk stratification. Low, moderate, high. Low risk, they've got a definable pathology, there's minimal psychological comorbidities, they're older than 45 years old, they're well motivated, they're engaged in the services. Active coping strategies, so patients that are doing well overall. Medium risk, a little different. They've got significant pain problems, they've got some psychological comorbidities, they've developed a little bit of tolerance but no physical dependence. There might be a past history of abuse, alcohol or substance use as well. They may have multiple pain sites. Moderate pain, moderate coping strategies, not coping just as well as you'd like. Medium risk. And then the high risk again, use specialist services, widespread pain, high levels of alcohol misuse, other substance misuse, major psychological problems. The younger person, less than 45. So 45 years may be a cutoff for you in terms of opioid prescribing. And they're not functioning and they're not coping. You're going to be considerate about prescribing opioids in these patients. Have a working differential diagnosis. So that means, is this facet joint pain? Is this knee pain? Is this fibromyalgia? Is this a neuropathic pain condition? So have a plan, have a working diagnosis. Define the nociceptive pain, define the neuropathic pain, define the psychological comorbidities, define function. Have a plan of action. Use non-pharmacological therapy. So you might want to, and the bottom of this diagram, the bottom of this graph is about rehabilitation. So physical, functional, psychological rehabilitation. Empower your patients, educate your patients, share with them what you're thinking. I know you do this anyway, but really define what you're thinking and why you're thinking, and focus on that first step. Lifestyle, wellness, use non-opioid medications, simple analgesics. You might try a short course of anti-inflammatories and paracetamol. If you think this is a neuropathic pain condition, use a short course of gabapentin. So think in terms of non-opioids, but again, think in terms of allied health strategies. And if simple allied health strategies are not working, use a pain service. If you're going to go down the pharmacological route or use or rational polypharmacy, kind of simplify the patient's chemicals and medications. Get them off the sedatives. If you've got sleep problems, don't use benzodiazepines. Use a tricyclic. Allegron, 10 to 20 milligrams at night. That's nortriptyline. Endip, 5 to 10. 10 to 20 milligrams at night. Endip's got a slightly stronger side effect profile than Allegron. So try Allegron if you're concerned. Or Phenadrine is a medication that I would challenge you to get comfortable with. That's Norflex. 50 to 100 milligrams 3 times a day. It's quite a good muscle relaxant, so it's not a benzodiazepine. It can be combined with Panadol, paracetamol. It can have some mild anticholinergic side effects, but it can be a really valuable medication for non-neuropathic pain conditions. It's been used widely in people with Parkinson's and stiff muscles, so think about using orphanadrine in your patients. Use anti-inflammatories or coxibs for a short period of time. Think about side effects. If your patients have got symptoms of depression, you might consider an SNRI or a newer antidepressant medication. So duloxetine 30 to 60 milligrams as start and titrate upwards in the morning. If that's not effective or too strong, don't stop there. Use another one. Try Effexor, 37.5 milligrams. See if they tolerate it and titrate upwards. So treat depression proactively if it's there. And if it's pure depression, treat it with an SSRI if you need to. Use adjunct medications, and one of them is clonidine, Catapres. It's quite a good anxiolytic. It's quite a good, I use it quite a lot for medication withdrawal, it can be quite a good mild anti-neuropathic medication as well. So think about adjunct medications. Have a contract, have a plan of action before you're going to go down this route of opioids with patients. Talk about side effects. Remember, we discussed this. If patients understand, they may be reluctant, they may want to try something else. Have an aim, not just pain control or pain reduction, but functional improvement. Patients got to show you that they're functioning better. Are they back at work? Are they engaged with life? You're going to have a trial. The trial might be 4 to 6 weeks. You're going to assess the patients during the trial and at the end of the trial, and at that point you have a go, no-go point. If it's not effective, then it's a no-go. You wean the medications. Don't just leave them. One prescriber, one dispenser, slow release preparations, we know about this. Have a trigger to stop your medications. We'll come to. Then you're going to trial your medications, slow titration, slow release. Keep the doses low. You don't need more than 50 milligrams of morphine equivalent per day. Certainly not more than 100 milligrams of morphine per day. I would challenge you not to use fentanyl. Certainly pethidine shouldn't be part of that algorithm. No injectables, no immediate release preparations, no other sedatives. Keep it simple, keep it clean, keep it slow release. Keep the dose low, reassess. Your trial of medications. So again, you're going to define what the trial is. You're going to have agreed outcomes, pain control, functional improvements. What are the goals that you want to get to? If a patient's not getting to those goals, then this might not be the therapy. Follow up regularly, every 2 weeks. Have an out strategy, have an exit strategy. We will be weaning and stopping these medications if the following happen. So the patient is on board. Use the lowest dose. Keep the dose low. The trial is going to last for 2 to 4 weeks, 4 to 8 weeks, 6 to 8 weeks. No more than a couple of months at most. Assess not only pain, but function as well, pre and post. There's something called the E1 or PEG tool. It assesses pain intensity, it affects enjoyment of life, and it affects general activity. So quite a good screener to see how your patients are doing. Prevent and treat side effects proactively. So if they're getting nausea, treat nausea. Treat and prevent constipation proactively. Try and reduce your side effect profile if you can. Most of us say regular assessment of the 4 A's, but I say it's the 6 A's. See your patients every couple of weeks. Assess analgesia, assess activities of daily living. adverse events and aberrant behaviours. Assess their affect or mood, and of course you want to document everything completely and utterly accurately. Reduce the risk of diversion. Use tamper-proof prescriptions. Prescribe small amounts. Have some random medication counts. Do some urine drug testing. So have a plan that you put to the patients. Now there are some safe practices that we can use in our clinics. I'm from Victoria, so we have Safe Script. I'm sure there'll be a time where this is rolled out, or each state has their own form of real-time Schedule 8 drug prescription monitoring, and it's been invaluable in my practice and certainly in the practices of GPs that I've worked with. You might want to have patient recalls, so have a list of patients on opioids, come back to that list regularly and see where they're at. Regular reviews. You might want to use permits for these patients so you've got some structure around things. And of course I've mentioned safe documentation. Have some policies of your practice. I'm sure you have this already. Have a look at your policies, update your policies, refresh your policies. Use parts of this lecture in terms of updating your policies. Big discussion, weaning of opioids. So when are you going to have your out? When are you going to come to your exit strategy? Well, I propose this. There are no functional improvements. There's no pain reduction. Your planned care package fails. There are aberrant behaviours, which I'll come to in a second, and the benefits don't outweigh the risks. So the risks kind of take over and the side effects take over. People on more than 100 milligrams of morphine oral equivalent per day, as it is now, my recommendation is they shouldn't be on that. There should be a plan. Now, I'm not saying just start weaning. I'll come to that in a second. But certainly, if the opioid dose is increasing, you might consider engaging your exit strategy. So what are aberrant behaviours? These are behaviours where you think a patient might be at risk or misusing these medications. They're concurrently misusing alcohol. They're concurrently misusing other illicit substances. They're not taking the opioids as prescribed. I see this a lot. They are very resistant to change when the discussion focuses a lot around opioids. You've got to ask yourself, what's happening here? What are you missing? Lost scripts, unsanctioned dose escalations. These are things that are common and familiar to all of us. Aberrant behaviours. Repeat scripts, lost scripts, stolen scripts, as I've mentioned, forging prescriptions, needing early refills. Then some very softer signs. You might find that patients are leading a chaotic life. And I find that's quite a good sign in picking up whether this is going to be a safe use of opioids. So if patients have chaotic lives, they've got chaotic thoughts and speech in the consultation, it just seems kind of exhausting. You might kind of consider if this is a reflection of their life and opioid use. Doctor shopping, yes. Hoarding medications, absolutely. I've got a lot of patients that say to me, I've got piles of opioids at home for when I need them. That's a worry for me. Patients talk about specific medications, that's a worry as well. And of course, if there's that aggressive type of behavior, either to you or members of your practice as well. This is from the Role of Opioids document from RACGP. Pretty straightforward. Have an exit strategy. You can effectively wean medications if there is no benefit or if the risks outweigh the benefits, as I've mentioned, or if there's a lack of improvement with the trial. Have your exit strategy. And of course, all GPs should be familiar with a plan of action for withdrawal processes. Now, I pause here for a second and implore each and every one of you, come back to your Hippocratic oath, first do no harm. In the space of the last 4 weeks, I've had 2 patients that have said to me, my relationship with my GP is broken down. This is a generalization, and I say this with great respect. My relationship with my GP is broken down. I've been told we are weaning. I am forced to go to the black market and get opioids that way, which 2 of my patients have done recently, and that is a worry. That is That is a worry because we've lost engagement with the patients. Patients are now going out and getting medications and we don't know what's in these medications or where they're coming from, and they're putting themselves in harm's way. So there is an argument not just to wean, but to have a plan of action, to develop a rapport. Dare I say it, use a pain specialist, use some pain services to help with this, this aspect. But the key is to put the foundations in place if this is going to be the plan of action moving forward, i.e. weaning. So this is from the RACGP document, and I'll read this. In all cases, patients have the right to respectful care that promotes their dignity, privacy, and safety. Absolutely, we all get that. Ending a relationship with a patient or abruptly discontinuing opioid treatment without offering a feasible plan for tapering or addiction treatment could be considered an abrogation of the accountable prescriber's duty. Yes. So we have to have a plan. Use a pain specialist, use an addiction specialist. Some of my patients I've turned to our addiction psychiatrist, and we've managed to get them into such a better place. Had a guy recently who was on 600 milligrams of OxyContin per day. It took me no less than 6 months to develop a rapport with him to get him to see to see our addiction specialist. Got him into hospital, stopped the medication, started him on Suboxone, and he's on a safe and small dose of Suboxone now. So this is about safety for these patients. Have a plan. Don't just discontinue or reduce medications. The patient's got to be on board. Opioid tapering is a great document from NPS Medicine Wise. Effectively, we know this already. If they're not improving, if the pain is not improving, if there's side effects of the medications, if the medication is intolerable, if there are a couple of other things as we've discussed, you may consider weaning, tapering. You can do it a fast way, you can do it in a slow way. A fast way might be about 10 or 25% of medications, just say about 10% every week. A slow way might be about 10% every month. So again, there's no right way of doing it, but you've got to have the patient on board and you've got to have a plan of action. Use pain specialists if you feel like this is going to be a difficult one. That's what we're here for. Just a couple of extra slides on a few things I wanted to refresh everyone's minds on. Substance use disorder, substance dependence, maladaptive pattern of substance use leading to clinically significant impairment or distress that lasts for about 12 months or over a 12-month period, and they have 3 of the following: tolerance, withdrawal. They're using larger amounts in greater over longer periods. There's a desire or unsuccessful efforts to control their substance use. And they talk a lot about it. There's a focus on getting that chemical, and it interferes with their life. And they know about it, but they continue to use it. I call it the 5 C's. So it's chronic, it's compulsive, there's controlling, there's craving, and there's continued use. Substance dependence. I just want to mention some unique opioid situations. Those on workers' compensation. I think if you're going to use any medication in any of these patients, you have to do it with caution, with a defined plan of action. And if you're not sure, don't. Workers' compensation patients have high levels of distress, have poorer outcomes on the whole, have higher use of opioid medications. So take care with that group of patients. Opioids and driving. There are no hard and fast rules of opioids and driving. The aim really is stable doses of opioids. If driving, you don't want to have doses or medications being mixed with alcohol and other sedative medications because it could put patients at higher risk. Comes back down to the lowest dose for the shortest time, and really talk about this to patients as well. Opioids and obstructive sleep apnea, sleep disorder breathing, same thing. Be careful. Follow all the steps we've previously discussed. Don't use other sedatives. Use the lowest dose needed. Have an exit strategy. Monitor the patient. Use specialists if needed. Same thing applies to the elderly patient. Be careful, be cautious. Use the lowest dose. Those patients with renal and liver dysfunction, things like buprenorphine, things like fentanyl, things like methadone have very little active metabolites and are relatively safe in those surroundings. But again, I don't think fentanyl is a good opioid for chronic pain per se, but you may want to use something like tapentadol in some situations. Go cautiously, take care. Same thing with different cultural backgrounds and inability to communicate with patients. I'd argue in terms of using maximum non-opioid therapies and allied health therapies and even pain specialist services before you're going to use opioids in these situations. Mental health conditions, take care. Because patients end up chemically coping with opioids and take them for the wrong reasons. And of course the big one is the inherited patient on opioids. Develop a rapport, understand the patient, go through those safe prescribing steps. Understand the medications, see if you can simplify and get the medications into safe doses and use pain specialist services if and when required. And then finally, when to use pain specialists. In terms of opioid management, look at the aspect on pain medications. If they're on moderate or high doses of opioids, so more than 40 milligrams, and it's not helping. If they're on higher than 100 milligrams, so they're showing tolerance, dependence, addiction, you should be using specialist services. In staying with medications, if the medications and non-opioids are not helping, if there's side effects with medications or their comorbidities, consider pain services. Specific pain conditions that you're dealing with, remember, diagnose the pain. If it's a neuropathic pain condition, and there are many, as I've mentioned on the slide, that are non-responding to simple first-line therapies, get them to a pain specialist. That's what we do. Same thing about nociceptive pain, so joints that are non-operative, hips, knees, shoulders that are or too frail and elderly for surgery or too early for surgery, get them to pain specialists. If they've had surgery on those joints, then they fall into the chronic pain after surgery category, and there may be some neuropathic pain that requires specific therapies. Nociplastic pain, we've mentioned elsewhere, the widespread pains, the primary pain conditions. And then of course if they're allied health, yellow flags, comorbid states, consider pain services. A lot of GPs I talk to say that allied health services or pain specialists should be used if there's psychology, depression and other diagnostic psychological diagnoses. That's only one aspect of where a pain specialist can be used, and as you can see from the slide, there are many avenues that pain specialists can support you in. And then we also help out in the preoperative setting sometimes, so high levels of pain, anxiety, catastrophizing, high levels of opioid therapy. We are there to provide the surgeons, the anaesthetists with a perioperative plan of action, and of course an early post-operative plan of action to prevent things from getting out of hand, because we know opioids in the acute setting can progress to opioids in the chronic setting.